our next lecture about acute respiratory failure. Acute respiratory failure may occur among patients with ARDS. Acute respiratory failure, sudden life-threatening deterioration in gas exchange, result in CO2 retention and inadequate oxygenation. High mortality rate up to 44%. The PaCO2 will reach above 50, the PaO2 less than 50, and the pH less than 7.25, in which indicate hypoxemia with respiratory acidosis. The causes: malfunction of respiratory centers, abnormal respiratory neuromuscular system, chest wall disease, airway obstruction. This may lead to hypoxemic, hypercapnic, which may result from ventilation perfusion mismatch, alveolar hypoventilation, impaired diffusion, right-left shunt, reduced O2, and mixed venous blood. There are three types of respiratory failure: hypoxemic failure, hypercapnic failure, or hypoxemic hypercapnic failure. Type 1, acute hypoxemic failure, abnormal O2 transport with increased alveolar ventilation resulting in low PaCO2, so that there is a decrease in O2 saturation, decrease in the level of oxygenation, result or causes from ventilation perfusion mismatch, right to left shunt, in which the blood retained from the right to the left side not being adequately oxygenated, and alveolar hypoventilation. The causes of hypoxemia: O2 delivery to alveoli impairment, O2 of the FiO2, and ventilation of the alveoli is impaired. Second cause: diffusion of O2 from alveoli to blood. There is a defect. The balance between alveolar ventilation and perfusion. Diffusion of oxygen across alveolar capillary membrane and the perfusion capillary membrane. There is a defect, and this may lead to abnormality in the diffusion of oxygen from alveoli to blood. Type 2, which is acute hypercapnic failure, inadequate alveolar ventilation, and elevation of CO2. Three main factors may lead to this type: decreased ventilator drive, like medication. Some types of medication may suppress the brain to initiate the respiratory process, which may lead to accumulation of CO2. Brainstem lesion, hypothyroidism, morbid obesity, sleep apnea. Also, respiratory muscle fatigue or failure caused by neurological dysfunction. 3. Increased work of breathing, as in COPD, asthma, pneumothorax, and pleural effusion. All of these may lead to the elevation of CO2 and causing acute hypercapnic failure. Third type is the combined of hypoxemic and hypercapnic respiratory failure. combined inadequate ventilation and abnormal gas transport. يعني بيرتفع ال CO2 وبنخفض الأكسجين في الارterial blood. Causes asthma exacerbation, acute asthmatic attack, emphysema, pulmonary edema, pulmonary embolism. Any cause of type 1 failure may lead to combined failure, especially if increased work of breathing and hypercapnia involved. يعني أي سبب يؤدي إلى type 1 قد يؤدي إلى type 3. History: baseline respiratory status and sign and symptom. Physical finding determine the need for intubation. Determine mental status like headache, confusion, loss of consciousness, دلالة على decreased oxygen supply to the brain. Presence of hypoxemia by ABGs, cyanosis, physical exam, hypercapnia on ABGs. Diagnostic test: ABGs to indicate the presence of high PaCO2, low PaO2, and decrease in pH. To detect the cause: X-ray, sputum, pulmonary function test, angiography, CT, CBC, bronchoscopy, and thoracentesis. All of these used to diagnose the underlying cause. What is the cause that may lead to acute respiratory failure? Manifestation: impaired oxygenation and restlessness, fatigue, headache, no energy because there is no adequate oxygenation, so that the patient may complain of fatigue, dyspnea, air hunger, tachycardia to compensate for decreased oxygen supply, confusion, lethargy, reverses use of accessory muscle, and decreased breathing sound and respiratory arrest. Correct the underlying cause. Endotracheal tube and mechanical ventilator may be needed. The ultimate goal is to increase the PaO2 and decrease PaCO2 by correcting the underlying cause. Continuous pulse oximetry monitoring until the O2 sat above 90%. As a nursing management, we have to monitor the patient responses and ABGs, monitoring vital signs, change position, turning, mouth care, skin care, and range of motion. Teaching about underlying cause and assisting in intubation procedure. The patient is completely depending on the nurse so that the nurse is responsible to provide a full care for the patient from head to toe. This diagram just clarifying the type of acute respiratory failure: mild, moderate, and in severe respiratory failure. Mild to moderate, the patient talks in phrases, prefers sitting or lying, not agitated, respiratory rate increase, accessory muscle not used, pulse rate 100 to 120, the O2 sat on room air من دون أكسجين يعني من 90 إلى 95%. و بالنسبة للسيفير talks and words كلمات فقط. sits hunch forward واقف وجالس وثاني حاله للأمام. agitated respiratory rate more than 30, accessory muscle using, pulse rate more than 120, O2 sat أقل من 90. This need careful monitoring, physical exam, sign and symptom, chest x-ray, ABG's result to diagnose and to help to differentiate between these two types also.